So we shall now go on to our next presenter, Dr. Amita Varghese, who's a medical director from Microsurgery and Laser Center at Kerala, and is again a specialist in phacoemulsification, glaucoma, and pediatric ophthalmology. And we look forward to watching her video and learning some more. On to you, Dr. Amita. You have to unmute yourself. Unmute yourself.
A very good evening.
Yes.
Yes. Yeah. Can I get the presentation, ma'am? Yes. A very good evening to one and all. I'm presenting a case of a cataract on the second eye of a 51-year-old male patient with a posterior polar cataract. The first eye had an uneventful smooth surgery with implantation of a multifocal plate haptic IOL. The surgery was done under topical anesthesia after making a capsulorhexis of about 6 millimeter in size. As the events unfolded, trying for a hydrodelineation, it became a hydrodissection. Without rotation of the nucleus, a trench was created and phacoaspiration was done under low parameters in the epinucleus mode. During the process, the nucleus prolapsed and flipped, and I could see the plaque of the PPC on the back of the nucleus. I could phacoaspirate 3/4 of the nucleus when I noticed a clear area in the posterior capsule, and there was resistance of the nuclear material to aspiration. I stopped at that point. I tried to inject OVD from the side port, but I could not do it. So I removed the phaco probe and injected OVD to keep the nuclear material from going into the vitreous. I could see a linear tear perpendicular to the main port. With the help of a vitrector, the nuclear material was cut and aspirated along with the anterior vitrectomy, and then cortex was aspirated in the IA cut mode. The retroillumination of the microscope helped in visualizing the rent clearly. As the rent was perpendicular to the port, I proceeded with the original plan to implant the planned multifocal plate haptic IOL.
The screen has become, has it the same? Yeah.
So now we can see the rent quite clearly. And I finished the cortical aspiration. And this is the intraocular lens implantation being done. And I try to center the IOL. At the leading one of the leading haptic was still outside, and I tuck it into the bag. And then I checked for the centration of the IOL at the end of the surgery. The 4-point fixation has helped in well centration of the IOL. Post-operatively, the patient has an unaided visual acuity of 6/6 and 6, but he did complain of some floaters. And this was because some of the nuclear material had fallen into the vitreous and it had dispersed. I think both the patient and the surgeon were lucky to come out of the difficult and tricky situation. I thank Dr. Chitra Ramamurthy and her team for giving me this opportunity. Thank you.
Thank you. Thank you, Dr.
This is a
Amita.
post-op picture.
No, the video has gone. Thank you very much, Dr. Amita. There were some important points which could be discussed. Dr. Rohit, could you enlarge for the younger audience about cut IA and IA cut and what parameters you should have when you're doing this?
I think it was a beautiful presentation by
Can you unmute yourself, Dr. Das? Background noise. Yes.
Yeah.
You have to unmute yourself. Yes. Dr. Jayanta Das, you have to mute yourself.
Yeah. I think the most important factor which we all should know, you're talking about cut IA and IA cut.
Yes, yes.
When you're doing vitrectomy, the most important thing is, first of all, you should visualize whether the vitreous is there or not. If by any means the vitreous is there, then you have to go into the cut IA mode, wherein you have to do the cutting with the maximum cut speed and cut the vitreous. And once you are sure that you have been able to get through with it, then you can go it into the IA cut mode. I'm not sure whether all machines do have that or not, but the machines which have that, this should be used to our advantage.
Yes.
That is the first thing which I would say that if we have to see, she, the way she managed it, I think it was outstanding how she did it. Yeah, but then, if a few things which I would like for the audience, in all patients with the posterior polar cataract, you need not go in for such a large rhexis as a 6 millimeter rhexis, as she said. Low IOP phaco is a very important part in this, because even if the capsule is open, if the IOP which you are using is around 24 or 26, that will not hydrate the vitreous. That will not that will not enlarge the the capsular tear to the periphery. Number two, and that will not push the nuclear fragments behind. So a low IOP phaco is a very important factor in those patients where you have an open posterior capsule. Another important thing which I would like the young audience to take home is, if you cannot make the rhexis circular, the posterior rhexis circular, try not to venture into putting an IOL in the bag, because while implanting the IOL, you can create a situation wherein there can be radialization and there can be a delayed, of the IOL going into the posterior segment. So if you can do a radialization, or if you can, circularize the posterior capsular tear, that is absolutely what we should aim for. And if you need to have the experience of Dr. Amita to go in and put an IOL in the bag in such a situation. Yeah. So that is these are the take-home points. And oval rhexis, which has been advocated, is also something which can be tried, because that gives the advantage of both a large rhexis and a small rhexis. So, yeah. And if by any means, if you have to use a trifocal lens, I think you can use a multi-piece, also a trifocal lens in the secondary stage if it is not available at that point of time.
Dr. Ramurthy, I want your thoughts. If it was a toric IOL and you have a single piece, what are your thoughts of doing a reverse optic capture in these eyes?
Well, I think very nicely managed, Dr. Amita. Difficult case and nicely managed. Yeah. Yes, the advantage of a pure multifocal is that you can implant the lens wherever the capsular support is there. Like in this case, she had it in the 6 o'clock, 12 o'clock meridian. So she could, she was seated temporarily and she could implant the lens in that Rather, she had it support in 3 o'clock, 9 o'clock, and she could implant the lens in that meridian. In toric intraocular lens, you do not have that advantage, and it has to be positioned in a particular manner. So in these situations, now that all of us are taking up these multifocals and torics more often, and they are not available in the three-piece platform, the conventional wisdom was that you never place these intraocular lenses in the sulcus. It's always in the back. If it's in the sulcus, then it has to be a three-piece. Nowadays, occasionally we have to resort to these gymnastics. There have been a few situations where, a couple of situations where we had a PCR in a case of a posterior polar cataract and a toric intraocular lens had to be implanted. I've done both a conventional optic capture and a reverse optic capture. In both these cases, basically the lens had to be oriented in the 0-180 degrees axis. And when there was support in the temporally and nasally, I actually implanted the lens in the back and created a reverse optic capture so that the lens was fixated. While when the support was lacking inferiorly and there was a tendency for the haptic to sink inside, I brought the haptics outside and created an optic capture. That's a conventional optic capture where the optics of the lens is held by the rhexis margin. So as Dr. Rohit said, creating a 4 to 4.5 millimeter rhexis in these situations is a good idea. It's always a good idea to use an ASOCT in these cases, evaluate the risk, and of course, pre-warn the patient that the multifocal or the toric might have to be given up. And as regards Rohit comment regarding converting the rhexis, that the posterior capsular tear into a circular rhexis, it is applicable to most instances, but sometimes it's not relevant to a posterior polar cataract, because like you saw in this case, it's actually what you get to a pole-to-pole tear. It's a splitting up of the PC that occurs in these posterior polar cataract, and there's really no way that it's going to extend. If it's just going to be a rent with a circular margin, indifferent margin, definitely the gymnastics of introducing a viscoelastic lens will extend the rhexis. But in these cases, we are able to do a good anterior vitrectomy and then position your lens accordingly. Sometimes making a circular rhexis is not necessary, or it's quite difficult also.
Dr. Gaurav, everything has been said. Anything to add, or shall we go on to our next?
I would only say that a word of caution that plate haptic lenses have a very funny way of, dislocating through a broken posterior capsule. Sometimes even from a small laser capsulotomy, they kind of expand it and they will find their way into the vitreous cavity. So I would be very, very reluctant to put a plate haptic lens with a broken PC of the kind that was there. But ma'am, you managed it so well. So it looked very elegant, but we don't know about what's going to happen later. Sometimes, I mean, there's a strong risk of these AIOS kind of rotating or even going behind. So I would probably have done a three-piece with an optic capture here, in spite of the fact that it was a multifocal. So it was kind of a very tight situation to do that, but I would probably still have gone with a three-piece monofocal or whatever,
Yeah.